all in the room now, so I want to go ahead and welcome you all to this presentation of Symposium, especially to our presenter, Dr. Sarah O'Brien. Tonight's session will be from 7 o'clock until 7:50, and we are honored to have Dr. O'Brien with us this evening presenting topics for women. Before we begin, I would like to take a minute to thank our sponsors for this event. We are so grateful for their continued support even through a pandemic. I want to encourage all of you to head over to our Symposium platform website and visit all of these exhibit halls that were put together with expertise by our beautiful comms team. I want to remind you that throughout this presentation, you will not be able to speak, but you can be active in the chat and sending any of your questions for Dr. O'Brien into the Q&A box, and we encourage you to do so. If you have any technical difficulties, please head to our Slack channel, #helpdesk. And without any further ado, I would like to introduce again Dr. O'Brien.
Hi, thank you, Jeanette.
There you go. You should be able to share your screen now.
Look good?
Looks beautiful.
Okay, and the volume is still okay?
Yes, ma'am.
Okay, perfect. Well, thank you everybody for taking time out of your evening or late afternoon to join us today. It's really my pleasure to be here and talk about a topic that sometimes doesn't get the attention that it deserves. And what we're going to be going over today is a pathway for best care throughout the reproductive years. And I'm going to try to hit on a variety of life stages. And I've tried to make the talk relevant to folks, no matter what bleeding disorder you may be living with or have family members living with. So I'll try to point out when something may be applicable to a particular illness, but many of these are broadly applicable issues. I am Sarah O'Brien. I work at Nationwide Children's Hospital, which is part of the Ohio State University, and we are located in Columbus, Ohio. So I am a pediatric hematologist, so I take care of children, adolescents, and young women. But I certainly see the issues that my patients' mothers may be experiencing or their grandmothers. So I think, we're privileged in hematology to get to know the whole family. And so while I'm certainly not an expert in some of the issues that I'm going to be touching on today, I certainly have an appreciation for how they can affect quality of life. My goals during this session are to make sure that everybody recognizes that there are symptoms that may occur across the lifespan in women living with bleeding disorders. And at the end of the talk, we're going to focus on the association between menstrual bleeding and iron deficiency, but I want you to also keep that in mind throughout because it is an issue for our patients throughout their reproductive years. I hope that you will come away today with recognizing that we do have many treatment options available for our patients with reproductive bleeding. And our goal is that we hope that fewer women have surgery for these issues as we move forward and have more and more wonderful medical options available. And then finally, I'm going to try to pause throughout and identify opportunities where you as a patient or as a family member can help advocate to receive best care. So I have this little visual in the corner here. And when we have that visual throughout the talk, that's a slide where we're going to focus on what can you do to help improve the care that you or your family member is receiving. This figure is part of a medical education initiative that I'm privileged to be a part of, done by the Core 2Ed Medical Education Company. And I love it because it clearly shows how bleeding symptoms can be different during childhood versus adolescence, adulthood, and late adulthood. And my hope today is to go through these same 4 phases, but to particularly focus on reproductive bleeding issues. So we'll have 4 patient stories that we'll briefly discuss this evening. So our first patient is a 11-year-old female with type 1 von Willebrand disease. And she's been followed in hematology for several years. She initially presented with easy bruising and nosebleeds. And she is coming to clinic today just for her routine annual visit. But during the visit, mom raises some concerns and worries that she's having. She's noticed some breast development and other signs of puberty, which of course is completely appropriate for an 11-year-old, but it is making mom suspect that Keisha's menses may start soon. And that is giving both Keisha and her mom some anxiety because they're worried that because of her bleeding disorder, Keisha may be at risk for heavy menstrual bleeding, and they don't know quite what to expect. And Keisha shares that as some of her friends have started having their period, it's just making her more anxious about what this might be like for her. So first of all, let's talk a little bit about what to expect. And it's important to know that menses can start at a variety of ages. We start to see it in girls as young as 8, and it's normal to start your period anytime between the ages of 8 and 15. In the United States, the average age of starting your first period is 12. So Keisha and her mom are right. They're certainly right at that time point where you would start to prepare for this. And then in terms of what to expect with the bleeding, these are the things that I talk about with my patients. So typically a menses would last about 4 to 5 days. The average cycle length is anywhere from 34 to 35 days, and most women will have cycles that are lasting somewhere between 3 weeks and 6 weeks. The first menstrual cycle is usually the longest, so it's not uncommon for a patient to have their very first period and then for it to be a while before that second period comes. And it is definitely not uncommon for young girls to have irregular menstrual cycles. The primary reason that young women have irregular cycles when they first start having periods is due to something called anovulatory bleeding. And this is a common cause of abnormal menstrual bleeding in teenagers, and it's due to immaturity of the hypothalamic, pituitary, and ovarian axis. And how I explain it to my patients is we all have hormones in our brain, and we also have hormones in our pelvis. And it can take a while for the hormones in our brain to learn how to talk to the hormones in our pelvis and vice versa. And this takes about a year or 2 for our bodies to really figure out this new menstrual period. And because of that, irregular cycles can occur in the first 12 to 18, sometimes even those first 24 months after a woman experiences menarche, which menarche is the medical term for the first period. And during this time of anovulatory bleeding, menses can range anywhere from light to heavy. But the other reason it's important to be aware of anovulatory bleeding is because this is a common reason why bleeding disorders get missed in young women, because they present with heavy menstrual bleeding and the healthcare provider may think it's just due to anovulatory bleeding, you'll outgrow it. But it's important to remember that heavy menses can be multifactorial and that women with underlying bleeding disorders also experience anovulatory bleeding. So there have been several studies showing that when you talk to women with bleeding disorders and ask them to kind of look back over their reproductive years, it's quite common for patients to recall that their periods were at their worst right when they started, and then again when they were heading into menopause, because as we'll talk about in a little bit, that's another time frame when you can experience anovulatory bleeding. So we never want to dismiss heavy menstrual bleeding especially in a young woman who has a family history of bleeding or who has other bleeding symptoms. When I'm meeting with a patient and kind of going over what to expect with your period talk with them, these are the red flags that we talk about. And this comes from Project Red Flag that the National Hemophilia Foundation did about 20 years ago now to increase the recognition of bleeding disorders in women. So we talk about that any period lasting more than 7 days is unusual, soaking more than 4 to 5 products per day, requiring double protection, meaning having to wear a pad and a tampon at the same time, or maybe 2 pads at the same time. It's actually unusual to have to get up at night and change your sanitary products. So we also ask about that. Experiencing gushing is abnormal. So I will typically ask my patients who are, when you get up from class at school to go from math class to science class, do you ever feel like your period is gushing out of you? And finally, we talk about passing clots. Passing small clots is very normal, but if you're typically passing clots that are greater than the size of a quarter, then that is unusual. One other thing to keep in mind is that these red flags were developed back when most women were using a quote regular size pad or a regular size tampon. And we have so many more products on the market today. We have super tampons, we have ultra tampons, period panties are becoming more and more popular. And so it's important to recognize, and as physicians, we ask very detailed questions of our patients about what kind of products they're using and how many they're soaking per day. So just keep that in mind. You know, if your daughter is using ultra tampons, then maybe even soaking 2 or 3 of those in a day would be considered heavy menses. So how can we advocate as we are approaching menarche? So I definitely recommend scheduling a period prep visit with your hematologist. And this can be aligned with your annual visit as well. And during that visit, you want to come away understanding what an expected menses would look like and what red flags to watch out for at home. And any one of the items in that list would be considered normal. Many of our patients will check multiple boxes in that list, but even if you're just noticing 1 or 2 at your at home, we want to know about it. It also can decrease a lot of anxiety for our patients to have products available, even if they haven't started their period yet. Just knowing that they have something in their locker that they can use, something at home, something in their suitcase if they're traveling, as you start to approach that time. And as I mentioned before, period panties are really becoming the rage in my young patients. And before you had to try really hard to find them online, now they're much more available in stores. And so this can be something I think that's really nice for young girls, because they don't have to worry about like how it works or how to put it on. They can just like another pair of underwear, but something they could have available in their locker if they need it. We always encourage our patients to track their menses either with a paper diary, or there's lots of mobile apps available. My personal favorites, there's a million on the market. I like Clue, C-L-U-E. I like Flow, F-L-O. I don't have any affiliations with those companies, but many of these mobile apps are really focused on women who are trying to get pregnant, and it can be really complicated. And our young patients, that's not what they're using these apps for. So I like Clue and Flow because they're quite simple and really are just about tracking menses. We also will often have a supply of tranexamic acid, or you may know it as Lystida or aminocaprolic acid, or you may be familiar with the trade name Amicar. So we will keep these medications at home. So if that first period is heavy, our patient can call us, we can go over what they're experiencing, confirm whether this sounds heavy, and instruct them on using the medication. That way we're not struggling with racing to the pharmacy, dealing with prior authorizations. The family already has what they need at home. And of course, many of us are struggling with the lack of nasal DDAVP right now, but that once it becomes more widely available again is another great option to have at home. So let's move a little later, and our second patient is someone who's already having her periods, and she is coming to hematology as a new patient due to heavy menstrual bleeding. Her mother also has a history of heavy menstrual bleeding as well as postpartum hemorrhage. And there's also a maternal grandfather who has mild hemophilia. This is based on a true story of one of my patients. And what I found fascinating about this visit was that it had never occurred to the mother that her family history of hemophilia could be related to her symptoms or her daughters because they were females. And we're going to talk about that a little bit in this section of the talk. When I checked my patient's lab results, her factor VIII was on the low side, but within normal limits. But we did do genetic testing, which demonstrated a variant of unknown significance in her factor VIII gene. I'll admit that the grandfather was a bit reluctant to undergo genetic testing. His doctor was also telling him that there was no way that his granddaughter's bleeding was related to his hemophilia. But eventually he did undergo genetic testing and was found to have the same factor VIII gene variant. So then, of course, we knew that it was a variant of significance. And my patient is currently doing really well on oral contraceptives for her heavy menstrual bleeding. So we're going to talk about two things in this section. First, women and girls with hemophilia can bleed, which probably seems obvious to most of you in the audience, but I always emphasize this point when I am giving talks to healthcare providers, because this is still a far too little known fact. And then we'll segue from this topic into just kind of briefly giving an overview of all of the different treatment options we have for heavy menses. This slide is from a group of investigators at Vanderbilt University, and they took a population of women who were known to be carriers for hemophilia A and compared them to a population of control women. And as you can see, across the board, almost every single bleeding symptom was significantly more common in women who were hemophilia A carriers. And some of the most common bleeding symptoms were heavy menstrual bleeding, easy bruising, post-surgical bleeding, and excessive bleeding after pregnancy or after dental extractions. One thing that's important to realize is that among women, the link between the factor level and bleeding symptoms is not consistent. In men, this is much simpler. We can see a patient with severe hemophilia, moderate hemophilia, or mild hemophilia, and we see what their factor level is, and we know whether it's mild, moderate, or severe. And we can give that patient or family a rough idea of what type of bleeding we would expect. For example, would we expect spontaneous joint bleeds? Would we not expect spontaneous joint bleeds? In women, we don't see this strong link. So this is a figure from an example of one of the studies looking at this. And on the x-axis, which is the horizontal line on the bottom, you can see the factor level. So it's going from a factor level of 0 up to a normal factor level of 0.5 and above. Then on the y-axis, or the vertical line on your left, is the bleeding score. And you can see that as the factor level increases, that the bleeding scores sort of go down, but there's definitely not a perfect correlation. And there are a lot of women who have normal factor levels, but unusual bleeding scores, meaning their bleeding score is over 5. So you see a lot of people like that, their bleeding score is over 5, even though their factor level is over 0.5. And you also see a few women that have low factor levels, but normal bleeding scores. So it can go either way. I think this slide is the most compelling way to tell this story. This is a slide representing one single family. So this is a large Amish pedigree of factor 9, a factor 9 family. And so all of these women have the same exact mutation. But even though they have the same exact mutation and they're in the same family, you can see that their factor 9 levels ranged all the way from 19% to 114%, and their bleeding scores ranged all the way from 1 to 8. So a lot of variability even in the same family. So now that we understand that, yes, women and girls with hemophilia can bleed, even if they have a normal factor level, and we need to learn a lot more from our scientists about why that happens. Now I want to talk about the different treatment options we have to help with this bleeding. Our first line treatment, both for women with or without bleeding disorders, is combination hormonal contraceptives. These medications are available as pills. They are available as a patch. They're also available as a vaginal ring. And they all work similarly. And how they work is they thin the lining of the endometrium, which reduces menstrual blood loss. And that's why any woman periods typically get lighter when they start a birth control pill, even if they don't have a bleeding disorder. These medications also have additional benefits, especially for the teenagers and young women that I take care of. They regulate the menstrual cycle, so my patients can know exactly when their period is going to start. They work to reduce menstrual cramps, and they can also help improve acne. One point I want to make is that if one is starting a combination hormonal contraceptive pill, you want to make sure that your healthcare provider is prescribing you what we call a standard low-dose monophasic pill. These pills contain 30 to 35 micrograms of estrogen, and they are all the same color. So if you look at the pictures on the right, this picture at the top is what you want the pill to look like. You want 3 weeks of all the same pill, and then a week of placebo pills, or sometimes people call them sugar pills, at the bottom. Sometimes, especially in young women, I find that pediatricians or gynecologists want to prescribe what we call the ultra low dose pills with 20, 25, sometimes even 15 micrograms of estrogen, because they're thinking, young patient, let's use a very low dose. But the problem is those doses don't work for heavy menstrual bleeding. You also don't want a triphasic pill, which these are fancy pills that try to mimic the menstrual cycle more closely and change the variation in the hormone ingredients over time. That's what this picture on the bottom is. Each color is the hormone composition changing in the pill. Again, they do not work well for women with bleeding disorders. Our patients tend to break through them. So you want the regular dose pill, which is a low dose pill, not the ultra low dose. And you want all the same color or monophasic. So yes to the top, no to the bottom. And I like to harp on that point because I see this mistake made a lot, and it makes patients give up on these medications. And it's just that they're on the wrong one. And oftentimes we can find a different one that works great for them. We are starting to use more and more IUDs in our patients as well, even in our young patients. These agents are generally more effective than oral medications in treating heavy menses. It is important to note that close follow-up is important. All women will typically have irregular bleeding for about 4 to 6 months after the IUD is placed, which for most women is simply a nuisance, and then it goes away, and many women have almost no bleeding after that. But for our women with bleeding disorders, there's some emerging evidence that the irregular bleeding may be more problematic for our families. And so there's some, but inconsistent evidence of increased expulsion in women with bleeding disorders. So for many of my patients, for example, if they're already on a pill and they decide to switch to an IUD, or maybe they're starting with an IUD as their first choice, we will often use a hormone pill for them at the same time for those first 4 to 6 months, just to get over that hump of the irregular bleeding. And that seems to help a lot. So it's definitely something that you can talk to your physician about if you're thinking about trying an IUD. I wanted to go over some of the common misperceptions, especially because I take care of young patients and these worries come up a lot. Sometimes my moms are worried that the IUDs will cause infection. And that may have been true of the old IUDs when they first came out, the metal ones, but that is not the case with the ones that we use today. There's also concern that IUDs can affect fertility, which is not the case at all. As I explain it to my patients, you're as fertile the day it comes out as you were the day it went in. So it really does not have any long-lasting effects. Sometimes teens worry that they can only get an IUD if they are sexually active, or they're worried that getting an IUD somehow means that they will lose their virginity. So we talk about why that is definitely not the case. And we have many young women who have IUDs who have never been sexually active. At our children's hospital, and many children's hospitals have this available now, are young patients who maybe have never had a pelvic exam before or are very nervous about that can have an IUD placed under light sedation. So that is also an option. The final one is that IUDs can only be placed in women who have delivered a baby, which again is not true. I don't want to spend a ton of time on this slide, but I want to take a moment to recognize the fact that some of our patients cannot use estrogen, which is what is typically in birth control pills. And that may be because they have a higher risk of blood clots. Maybe they have migraine with aura, for example. Maybe they have an inflammatory illness like lupus or severe diabetes that makes us worried about using estrogen for them. Or maybe they not only have a family history of a bleeding disorder, but also a family history of blood clots. So for these patients, we use progestin-only options, which are safe for women at risk of or with a past history of a blood clot. And the IUD that I just mentioned, those are progestin only also. So are safe choices for women with bleeding disorders and for women with clotting disorders. The one point I wanted to make at the bottom is regarding the progestin only implantable. The brand name for that in the States right now is called Nexplanon. And this is a tiny rod that is inserted under the skin in your upper arm, and it provides contraception for approximately 3 years. These are great choices for women with normal menses who want excellent contraception. So in that population, they work great. For our women with bleeding disorders, we have not had such great success with this agent. So I just wanted to make sure I'm bringing that to the audience's attention. And in fact, sometimes when we're meeting our patients for the first time, we can't make any headway until we have had the rod removed. So when you're going over choices with your healthcare provider, this would not be my first choice for our families with bleeding disorders. And then finally, I'll talk about some of the non-hormonal options. We've already mentioned antifibrinolytics, such as tranexamic acid and aminocaproic acid. These are medications that you may be familiar with because we've used them before or after a surgery that you've had to help prevent bleeding. They can also work well for heavy menses, although they work best in the setting of a regular menses. So these are great choices for young patients, maybe patients that do not want to have to worry about taking a hormone pill every day. Maybe they're not on any other medications that they have to remember to take every day. Because that's the nice thing about these medications. You only take them for 5 days during your period each month. And they are generally very well tolerated. Factor replacement is something that most of our patients do not need, but it is an option if hormonal options are not working. It's also a nice choice for maybe somebody who is trying to get pregnant. So we've taken away the hormonal options, but now we need something else to treat the menses until the time they become pregnant. Antifibrinolytics are a great choice for this. And for some patients, factor replacement can be as well. This can be used for women with von Willebrand disease, von Willebrand factor. It's not well studied. It's even more poorly studied in women with hemophilia, but there are some small pilot studies ongoing to look at factor 8 and factor 9. And now that we have extended half-life products available, that lends itself even more nicely to being able to help with menses. So before we shift gears, just a little bit about advocacy. So one, just being aware that women who carry the gene for hemophilia may have excessive bleeding, even in the setting of a normal factor level, and not being afraid to share this knowledge with your medical providers. Because unfortunately, while we're working very hard as hematologists to spread the word, there are still a lot of physicians and other healthcare providers who just don't know this. And so they may need you to alert them to the fact that your bleeding could be related to this family history. And if you are having reproductive bleeding and not feeling like you're getting what you need from your healthcare provider, feel free to advocate for yourself and seek a second opinion or change providers so that you feel comfortable with the person that you're seeing. Know that many treatment options are available to manage heavy menses, both for women seeking and not seeking pregnancy. I know that the CDC has a list of hemophilia treatment centers on their website. The Foundation for Women and Girls with Blood Disorders also has the Learning Action Network site list on their website, which is a list of clinics across the country dedicated to women and girls with blood disorders. So that is another great place to, if you're interested in seeking a second opinion or are looking for a healthcare provider. Now we're going to shift into our third patient and we'll talk about pregnancy a little bit. So now we have a 31-year-old female who has type 1 von Willebrand disease, and her baseline levels are rather low in the teens. And her past symptoms have included easy bruising, epistaxis, and heavy menses. She's now in her third trimester of her first pregnancy, and the pregnancy has been going very smoothly. At today's visit, her third trimester von Willebrand levels are measured, and while they have increased with pregnancy, they are still mildly low. They are in the 40s, and our patient knows that she wants to receive an epidural during her labor. So it's important to be aware, of these new guidelines that come about through a collaboration between ASH, ISTH, NHF, and WFH. And they came out with guidelines both for the diagnosis and for the management of von Willebrand disease. And these guidelines are freely available to the public on these societies' websites. We're also in PubMed or in the Blood Advances journal, that's Blood Advances. So easily accessible for patients and families. And they also have materials making these guidelines more accessible to patients and families. I just want to talk about two of the recommendations from this guideline. So one recommendation is talking about epidurals in women with von Willebrand disease. And I think that this can definitely parallel to women with hemophilia as well. So you want to make sure that you're targeting a factor level of at least 50% for a woman before she would have an epidural placed. One point that the panel makes is that this is really just focusing on the epidural, and we really still don't know what levels of factor our patients should have after pregnancy in order to prevent postpartum bleeding. For women without von Willebrand disease, von Willebrand levels may go sky high during their pregnancy, and they may have levels over 150%. Should our patients also have those levels? We just don't know that answer yet. But we definitely know from the literature that we need an activity level of 50% to safely do an epidural. So it's important to have those levels checked during the third trimester so that you know exactly where the levels are and you can make that plan with anesthesia for the epidural. And you want to make sure you're keeping those levels above 50% for at least while the epidural is in and for at least 6 hours after it comes out. Postpartum hemorrhage is fairly common even in the general population. In fact, 3% of women will experience primary or immediate postpartum hemorrhage, which occurs in that first 24 hours after birth. And 1% will experience more delayed postpartum hemorrhage. In our patients living with bleeding disorders, that risk goes even higher to 7 to 10%. And it's important to understand what are the hemostatic changes during pregnancy. So pregnancy is an amazing condition that really affects every single organ system in our bodies, including our coagulation systems. So for patients who have factor VIII deficiency or von Willebrand disease, their levels will go up during pregnancy. Factor IX does not increase during pregnancy. So just a difference to keep in mind. What are the strategies we can use to avoid postpartum bleeding? So one is to make sure you have early involvement of your hematology providers during pregnancy. We don't want to get involved, a week before you're about to deliver, because we want to make sure we have time to come up with a great plan and to communicate that plan to all of the providers involved. As we just discussed, we want to make sure whether factor replacement might be needed at the time of delivery, and to allow for any woman who wants to have an epidural to be able to have that choice during labor and delivery. Tranexamic acid, which keeps coming up, is a very helpful agent here. And I always prescribe this for my patients while they are pregnant so that it's already at their house. So again, we're not rushing around after delivery trying to get a new medication. And this is a medication that we have our patients take for about 2 weeks at home during that time when postpartum bleeding is occurring. Ibuprofen and similar medications are often used as pain control after delivery. We don't want our patients to receive these agents because they can inhibit platelet function and worsen bleeding. But there is one NSAID called celecoxib, or Celebrex is the brand name. And that is one that does not inhibit platelet function and would be safe to use. So again, much better to have these conversations up front so that you already have adequate and safe pain control available to you afterwards, rather than trying to rush around and switch an ibuprofen prescription at the last minute. Also, traditionally, women have a 6-week postpartum visit. We want our patients to have an early postpartum visit. We want you to get back to your healthcare provider at about 2 weeks so we can assess how the postpartum bleeding is doing, hoping that it is resolved by then, intervening if it is not, and making sure that iron deficiency or iron deficiency anemia has not developed. And I won't go through this slide in detail, but just to make you aware that the guidelines that we mentioned do support this use of tranexamic acid during the postpartum period, and also making the point that this medication appears to be safe to use for women who are breastfeeding as well. So advocating during pregnancy, we talked about creating that multidisciplinary team early on. That should be your local OB-GYN or midwife. Sometimes our patients will also need a maternal fetal medicine specialist at the nearby academic center. You want your hematologist on the team, genetic counselor, anesthesiology as it gets closer to delivery. Once we've come up with your plan, we want to make sure that our patients also have a copy of it. Sometimes things don't go as planned. People may be delivering in a hospital they weren't expecting to. So we want you to have that information with you. And then making sure that all of these things we talked about are lined up. Do you have your pain medication that's safe for you to use? Do you have your tranexamic acid at home to use? Is your healthcare provider monitoring you for iron deficiency during and after pregnancy? Now we'll do our last patient in our last few minutes. And our last patient is a 45-year-old symptomatic hemophilia carrier. And she has a long history of heavy menstrual bleeding. She has been using oral contraceptives since the birth of her second child 10 years ago and had been doing really well on that. However, over the past 9 months, she's been noticing progressively heavier menses. She's also having worse cramping, and she's getting some hot flashes during her menstrual periods. She also reports this new feeling of pelvic heaviness that's worsening, as well as fatigue and decreased exercise intolerance. During that first visit, lab studies reveal a hemoglobin of 10 and a ferritin level of 5, which ferritin are our iron stores. So this patient has developed mild iron deficiency anemia as a result of her bleeding. That's probably the cause of her fatigue and decreased exercise intolerance. We mentioned before that anovulatory bleeding occurs again during perimenopause. So women with bleeding disorders are going to have an increased risk of excessive bleeding during this time frame. But now my message to you is going to be the opposite. So when we talked about those early years of menses, I said, don't dismiss the menses as due to anovulatory bleeding. Make sure you're paying attention to the possibility of a bleeding disorder. Now I'm going to say the reverse. Even if the woman has a known bleeding disorder, do not dismiss anovulatory bleeding during perimenopause as simply being due to the bleeding disorder. The reason is that structural causes, because of heavy menses, become much more common during this time frame of our life. So you need to make sure that you're ruling out fibroids, polyps, endometrial hyperplasia, or cancer. Once you've ruled out all the structural causes, then you can focus on the bleeding disorder and start the appropriate treatment. And for this woman, one of her symptoms was pelvic heaviness. So again, that's automatically making me wonder, does she have fibroids? And we need to look for that first. And this patient also has iron deficiency anemia. Iron deficiency anemia with iron deficiency with and without anemia is commonly found in women with reproductive bleeding. And we see this in our patients through the early years of menses, pregnancy, postpartum, perimenopause. Iron deficiency can occur at any phase, so it's really important to be vigilant about it. And sometimes people don't realize that you can have symptoms due to iron deficiency even if you are not anemic. So it's very important that your healthcare provider is checking not only your hemoglobin every year, but also your ferritin level to see where those iron levels are. Here are some of the most common symptoms of iron deficiency. And again, these can occur even if you are not anemic. Fatigue is definitely the #1 symptom. Shortness of breath with physical activity is another one. Increasing headaches, dizziness, lightheadedness, having cold hands and feet. Sometimes patients will chew things when they are iron deficient. Chewing ice is the most common. And athletes will notice a decreased endurance and performance. Or even, not a professional athlete, but somebody who's a regular exerciser will notice that they're not able to run the same times they used to, or they can't perform at the same level during their exercise class. Ferritin concentration is the best marker of our iron stores, and that's what we should be using to diagnose iron deficiency. The World Health Organization came out last year with really clear, helpful recommendations about iron deficiency and defining iron deficiency as a ferritin of less than 15, and also having lots of great information and flyers just showing people what symptoms iron deficiency can cause and what time periods iron deficiency is most common. Like this poster points out menstruation, pregnancy, early childhood. And then the poster on the right is making the important point that low iron, even alone, can cause fatigue and less productivity and poorer physical performance. So how do we advocate as menopause approaches? Needing to rule out structural causes for heavy menses. Make sure your bleeding is not just being blamed on your bleeding disorder. Other causes need to be investigated. If a hysterectomy is recommended, ensuring that hematology has been involved and that really all medical options have been exhausted. If a hysterectomy is necessary, again, making sure you have your hematologist involved so that we can help make a plan to prevent bleeding during and after that surgery. And then again, to just make sure you're getting screened for iron deficiency, not just during this phase, but during all phases of the reproductive years. So that was a bit of a whirlwind, but I wanted to make sure that we left some time for questions. And again, thank you so much for everybody's attention to these really important issues.
Thank you, Dr. O'Brien. Really appreciate that presentation. I learned a lot myself, and I'm sure everyone watching and listening has also learned quite a bit. We do have some questions in the chat. And Dr. O'Brien, if you will stop your screen share, then we'll switch. Perfect. Thank you. All right, I'm going to begin with, just give me just a second here. Okay, here we go. So the first question in our Q&A is from Lisa, and she's wondering about a time frame to expect her 11-year-old daughter with von Willebrand's type 1 severe, a time frame of when to expect her first menstrual cycle, and perhaps she's wondering if there's a way to tell if it's going to be a bad first menstrual cycle or not. Is there a way to prepare for that?
Sure, those are great questions and really common questions as well. So in terms of the age, everyone is different. What typically will happen is once breast development starts occurring, the periods will usually start about a year later. That's a very rough estimate, but at least it's something to hold on to. So typically you'll see breast development, then you'll see pubic hair development, and then the menses are one of the later things. So just as you start to see those new signs developing, you'll have a better sense of when it may happen. If you are a family where periods tend to start late or periods tend to start early, that can also sometimes be a predictor. In terms of knowing whether the first one will be heavy, unfortunately, there's no way to tell. And sometimes I have patients where, I feel like we did all this fuss and then the first one was totally fine. And then some patients really do have a challenging one right off the bat. So I think that the most important thing is to feel as prepared as possible and making sure that you and your daughter know exactly what to look out for during those first few days. Having the tranexamic acid at home, knowing what numbers to call and not hesitating at all. Call after the first day. This is what's happening. Like, what do you think? And in particular for a patient with just having all the tools at your disposal ahead of time.
Wonderful. Thank you. I'm sorry if the timing is a little off. I'm experiencing a little bit of delay. We'll head to our second question. This is from an anonymous participant. Their teenage daughter is still experiencing heavy bleeding after the use of an IUD. Would it be beneficial to talk to her doctor now about adding an oral contraceptive? She's pretty bummed about having heavy cycles still.
Absolutely. No, and this would definitely be a good reason to talk to your healthcare provider about that. We have used typical hormonal contraceptive pills in this situation. Another agent that we commonly use is called agestin, and that's AYGESTIN, and I'm purposely using the trade name just because if I use the generic one, there are different dosing and it might be more confusing. But the one that we use a lot is called agestin. Yes, thank you. Lori Long has spelled it correctly in the chat for me. And we can sometimes use this at very low doses, and it really just helps to shut that bleeding down. And then what we'll often do is, if things are smooth 6 months later, we'll try to take it off and see what happens.
Excellent. Thank you, Dr. O'Brien. We have a few more questions in our Q&A, and then I see some in our chat too. All right. Vanessa asks, or she says, the pills worked for me. I'm not sure what pills she means, perhaps TXA pills. She has hemophilia A and endometriosis as well. And she's wondering how much research is being done about a connection between endometriosis and bleeding disorders.
Yes, more research needs to be done. We know that endometriosis is more commonly diagnosed in women with bleeding disorders. We are not sure if that's because endometriosis is actually more common in our patients with bleeding disorders, or because it's more likely to come to attention because you are more likely to experience heavier bleeding than the typical patient with endometriosis. But this is actually and it's an important thing for me as a hematologist to know about, because I need to know when is a symptom starting to seem more like endometriosis, because we do have patients that have both. So it's an excellent point that we don't know that there isn't evidence that one causes the other or anything like that, but definitely if you have endometriosis, it will likely have worse bleeding.
Okay, interesting. Thank you. Okay, we have one final question in the Q&A, but I also see a few in the chat. If we have time, I hope so. So final question here in the Q&A. Premenopausal mild hemophilia A patient was previously on Selexib, yes, and the insurance made them switch to meloxicam for arthritic pain, but one of the product insert warns against bleeding disorders. So should they be concerned?
Yeah, I would have really, I'm going to say Celebrex because I can barely pronounce the generic name either. It's really the only one that is truly an NSAID. So, and truly does not inhibit platelet function. So sometimes I would say that my personal experience is if I do a prior authorization and write a letter, that most insurance companies will then understand why we're picking that particular agent.
Mm-hmm. Wonderful. Okay, questions from the chat box that I'm seeing. When do you think women should have their first factor levels tested, especially if there is a history in the family of hemophilia?
Sure. And I think that it depends. So certainly if somebody is having a bleeding symptom, then I think that would be a time to start checking the factor level. I also think that even if somebody has not had a bleeding symptom, if they have a major surgery coming up, they need to have a tonsillectomy. That would be another reason why I would want to check a factor level ahead of time. I think also as approaching menarche would be another time so that I can help advocate for the patient, let them know what they might expect during their menses. So I think as soon as the information may provide value, I think if you check when the child is very young, you run into the problem of the factor level being artificially elevated because of the stress of the blood draw itself. So that's why we sometimes wait a little bit before checking the level.
Okay, excellent. Thank you for that. Two more questions I hope we have time for. What do you recommend for iron deficiency anemia?
So in terms of an oral medication, usually the one that we suggest first is called ferrous sulfate, Ferrous sulfate, Sulfate, and that can be found at any drugstore. Every drugstore makes a brand for it. Thank you, Lori Long, again for being my speller. And what we're learning more though is that the less iron is better. So before we used to pile up iron on our patients. If they were really low, we would give it to them 2 times a day, 3 times a day. And we're learning now that that just makes people have GI upset and get very constipated. But actually the less iron you take, the better you absorb it. So now we only use 1 pill once a day for our patients who are anemic, unless it's severe anemia, of course. And then you can even back that off to every other day if you're having any stomach upset or constipation, and it will still work well. We try that first. If our patients are not responding to the oral iron, or they're not able to tolerate it, then we move to IV iron. Does it matter what time of day you take iron? And I heard that we shouldn't take it with calcium. Yes. Time of day doesn't matter as much, but you do want to try to take it with vitamin C and not with calcium. So it's best to do it like in the morning with some orange juice or another juice that contains vitamin C. Or for my patients that get a bit nauseated from it, they often prefer to take it at night right before they're going to bed. And again, not around mealtime, but just with a little bit of juice.
I received the same advice from my hematologist. So
Okay, good. Now we're saying the same thing.
Yeah. One final question that I see in here is, how often do we see fluctuation in levels? I'm assuming that's what the question is about, across life stages.
Great question. I think we need more research in this area. We definitely know that factor levels increase as we age. So most of this work has been done in patients with von Willebrand disease, showing that with each decade of life, our von Willebrand levels increase a little bit. What we don't understand well enough yet, though, is does that impact bleeding? Should you be, we don't want our patients to be undiagnosed with von Willebrand disease because their levels have increased when we don't understand how that really impacts bleeding yet. And you can see fluctuations for other reasons. If you've been sick recently, if you've had an infection, even they've done studies that even just like running around the block increases your von Willebrand level. It's very sensitive to stress, illness. During the menstrual cycle, it changes a little bit. So that's why it seems like we're torturing people sometimes, but that's why when I'm seeing a new patient, I will check their von Willebrand level 3 times before I convince myself that they don't have von Willebrand disease, just because of those fluctuations. The other thing to keep in mind, as we talked about, is that estrogen increases von Willebrand levels. So if you're on a estrogen containing birth control pill or you're pregnant, that's not your von Willebrand levels are going to be higher. So that's not your true baseline.
Wonderful. Dr. O'Brien, if you're willing, there are just a few more questions.
Oh, sure, I'm fine.
Okay, we're not waiting for a session to happen after us, so I hope everyone's okay with that. The question is, have you treated patients with platelet defects with factor or other bleeding products?
So for our patients with platelet function defects, just kind of quickly going through the life stages that we went through. For heavy menses, typically hormones, whether it's a birth control pill or an IUD, work really well for our patients with platelet function defects. During pregnancy, we use, and the labor and delivery, we will use antifibrinolytics, the tranexamic acid, before and after delivery. And for our patients where those agents are not working, then we would give a platelet transfusion if like we needed to during delivery, or if somebody was having a very serious operation, we might give platelets ahead of time, but often we'll have them on standby in the OR. But other than kind of keeping the platelet transfusion in our back pocket if needed, otherwise the treatment is very similar because they do respond just as well to the hormonal agents as patients with other bleeding disorders.
Wonderful, thank you. A final question is, what is ITT? And I kind of think she might mean, what is ITP?
Sure. So ITP is, it stands for immune thrombocytopenia, and it's an immune-mediated disease that lowers your platelet count. So it's a bleeding disorder in the sense that patients can present with bruising and bleeding, but it's very different than the other bleeding disorders we've been talking about today because it's not an inherited bleeding disorder. It's one that comes up suddenly. And for some patients goes away quickly. For other patients, it can become a chronic disease.
Dr. O'Brien, I cannot thank you enough for your time and efforts putting this together. We've all learned a wonderful, large amount of information today, and that is due to your expertise. So we thank you. I do want to encourage all the blood sisters in this presentation to continue this conversation in the Slack chat. # network-bleeding, network-blood sisterhood. I did share that link in the chat, so I hope you'll join us there to continue these conversations. And Dr. O'Brien, thank you again for your time and expertise. We appreciate you.
You're very welcome. It's my pleasure. Thanks for all the great questions.
I want to encourage everyone to fill out the session evaluation that will pop up as you leave this session. Don't forget to add your name so that you can be included for the to possibly win the prize. And then we'll see you tomorrow for day 3 of Virtual Symposium. Thank you for being here.
Thank you, Jeanette, for hosting.
Thank you.